Hi all, this is Pulmonology tailored to the high yield emergency medicine shelf examination and review. So starting off with asthma, it's reversible bronchoconstriction. The treatment includes beta agonists. You can add on steroids if needed. The oral is preferred over the IV. You can add on magnesium as well to relax smooth muscles. And there may be some benefit in using magnesium in various exacerbations. And then lastly, if things are getting more ominous, you want to intubate the patient. A great induction agent for intubation is ketamine. And so the next question you have to ask yourself is what happens if an asthmatic patient goes into cardiac arrest. You want to disconnect the ventilator, compress the chest by applying external pressure, just like we do for CPR, and you want to place bilateral chest tubes and give a fluid bolus. Exercise-induced asthma, it's 5 to 10 minutes of onset after exertion. The prophylactic therapy is a beta agonist, which can prevent the attacks. And then aspirin-induced asthma, you'll see that more commonly in adult females. And while asthma is a reversible bronchoconstriction, COPD, on the other hand, is not completely reversible. The treatment, you want to keep saturations of oxygen between 88 and 92%. You want to add on oral steroids, and then BiPAP is good for COPDers as well, and you want to counsel on smoking cessation. There are 4 causes to consider in a patient that's intubated and deteriorating. Hypoxic and bradycardic, for example, you want to consider displaced ET tube, airway obstruction from secretions, like see if there's a resistance to bagging, pneumothorax, and equipment failure. The most likely cause of post-viral pneumonia, if you get something on top of it, would be a bacterial pneumonia, which is most commonly Staph aureus. Lobar pneumonia can be seen in alcoholic patients. You want to consider something like Klebsiella, and it's most commonly affecting the right upper lobe. Now, if you see GI symptoms such as nausea, vomiting, diarrhea, and pneumonia, think of Legionella, and that will often come from water sources like air conditioning units, for example. If you see a dry staccato cough, think about chlamydia. The treatment is oral erythromycin. And then treatment for outpatient pneumonia, think of things like azithromycin, doxy, amoxicillin. Inpatient, you're going to use fluoroquinolones or a combo of azithromycin and ceftriaxone. ICU pneumonia or healthcare associated pneumonia, you want to consider agents that cover MRSA and Pseudomonas. And then regardless of CD4 count, strep pneumo is still the most common cause of pneumonia in HIV patients. Pneumocystis carinii pneumonia, that's the most opportunistic infection in HIV patients. It's formerly known as Jirovecki pneumonia. You want to look for an increased LDH. And then on x-ray, you're going to see bilateral infiltrates, and the question stem may describe it as a bat wing infiltrate. The treatment is trimethoprim sulfa, and if there's an allergy to sulfa, you want to choose pentamidine. Consider an ABG to see if the patient with this pneumonia needs steroids, and that would be if the PaO2 is less than 70 and or the AA gradient is greater than 35. And the question becomes, what about aspiration pneumonia? What's the most common cause of aspiration pneumonia in hospitalized patients? Pseudomonas. If the aspiration pneumonia occurs in the supine position, the posterior segments of the upper lobes and superior segments of the lower lobes are more likely to be affected. And then if you're in the standing position, the right lower lobe is the most commonly affected, but the patients can have bilateral infiltrates. The most common cause of aspiration pneumonia within the community, that's again strep pneumo. What is the diagnostic criteria for ARDS, acute respiratory distress syndrome? So the diagnostic criteria for ARDS, or non-cardiogenic pulmonary edema, you're going to have acute onset hypoxia with a pulmonary capillary wedge pressure less than 18. If it's higher than that, you want to start thinking about cardiogenic abnormalities and diffuse bilateral infiltrates and edema. In these patients, you want to keep the tidal volume low and the airway plateau pressure low. You may see TB on your shelf, so let's run through the millimeters of induration and the treatment. So if greater than 5 millimeters of induration is positive in HIV, organ transplant, close contacts, or known exposures to tuberculosis patients. If it's greater than 10 millimeters in induration in healthcare workers, it's positive. Diabetics, IV drug users, and immigrants, it's also positive. And then greater than 15 millimeters of induration, that's, if it's positive, then that's in the everyone else population. Who do not have any TB risk factors. If the PPD is positive, you need to get a chest x-ray, and if the chest x-ray is negative, go with isoniazid for 9 months. If the chest x-ray is positive, get a sputum culture, and then if it's positive, you want to do the 4-drug RIPE therapy for 6 months. Reactive TB is more frequently seen in apical posterior long lobes, and miliary TB is when the TB has hematogenous dissemination. Active TB, the chest x-ray will have infiltrates in cavitary lesions and a presence of hilar adenopathy. The treatment is isoniazid, and remember, that will cause peripheral neuropathy and hepatitis. Ethambutol, which can cause optic neuritis. And then you want to also think about streptomycin can cause ototoxicity, nephrotoxicity, and rifampin can cause bodily fluids to appear red or orange. You always want to add on B6 for these patients as well. And then sarcoidosis, it's going to present with a multisystem granulomatous disease with non-caseating granulomas in various organs. The chest x-ray will show bilateral hilar adenopathy and pulmonary infiltrates. The most common extrapulmonary site is the skin, and labs may show hypercalcemia, elevated ACE levels, and anemia. The treatment is steroids. If you see an anterior mediastinal mass, there's 4 T's I want you to think about: thymoma, thyroid, teratoma, T-cell lymphoma, and terrible, meaning bronchogenic carcinoma. I guess that's actually 5 T's. So massive hemoptysis, it's defined as greater than 600 milliliters out in 24 hours, and that's what you consider massive hemoptysis. The most common cause in the world is tuberculosis, while in the United States it's bronchitis. And then a pulmonary embolism can present with dyspnea and chest pain. The most common EKG is sinus tachycardia. The most sensitive, you'll see right bundle branch block with right axis deviation and that classic S1Q3T3, which is seen in right heart strain. Thrombolytics are indicated in hypotensive patients and those who have right heart strain. Pulmonary hypertension is diagnosed with a mean pulmonary artery pressure greater than 25 at rest. The gold standard for diagnosis right now is right heart catheter. And there are 5 flavors of pulmonary hypertension, and to treat the pulmonary hypertension, you just want to treat the underlying cause. So a pulmonary hypertension secondary to a heart failure, for example, you want to treat the patient with diuretics.